Hello, my name's Stephen Anderson and I'm a consultant psychiatrist in the Adult Eating Disorder Service in Glasgow. I hope to be able to run through a few of the issues that might come up in relation to managing someone who has type 1 diabetes and also an eating disorder. This will be a fairly quick run through, but hopefully we'll be able to cover some of the issues, and I'm happy to be contacted at any point to discuss eating disorders in general. So what I would like to cover is just a little bit about eating disorders. I'm aware that in most professions training, we have very little education and training about eating disorders and often little clinical experience of working with people who have eating disorders. I'd also like to talk about some of the different combinations of eating disorder and diabetes. So the presentation will mainly focus on eating disorder with diabetes type 1, so ED, DMT1, which sometimes people call diabulimia, and we'll talk about the reasons for that term. It's also possible for someone to have an eating disorder and co-occurring diabetes, but without using insulin to manipulate their shape or weight, so quite separate from the eating disorder, but that will involve different diabetic management. And someone who has a binging eating disorder may end up overweight and developing insulin resistance and type 2 diabetes. I'd like to talk a little bit about the risk factors and warning signs that someone recently diagnosed with diabetes might be developing an eating disorder. We'll have a think about some of the ways that people might manipulate insulin in order to control their weight, and we'll talk about some of the management issues. So when we hear the term eating disorders, I guess for a lot of people the image that springs to mind is someone who is female and very underweight and may have anorexia nervosa. We know that eating disorders can affect anyone from any background, any gender, sexuality, ethnicity. And anorexia nervosa, in terms of population, makes up the smallest number of those with eating disorders. The majority of people with eating disorders would have a diagnosis of bulimia nervosa or binge eating disorder, or the other category there, which is other specified feeding and eating disorder, if they don't meet the full criteria for one of the other disorders. The last diagnosis there, ARFID, or avoidant restrictive food intake disorder, doesn't have the core psychopathology of the other eating disorders, so it tends not to be seen within eating disorder services at the moment. So anorexia nervosa, bulimia nervosa and binge eating disorder tend to have the same core psychopathology, and that is that the person's shape and weight and their eating and the control of that unduly influence how they perceive themselves. So from the diagnostic criteria, this is from DSM-5. So for a diagnosis of anorexia nervosa, there needs to be persistent restriction of energy intake, leading to significantly low body weight. There needs to be an intense fear of gaining weight or of becoming fat, or persistent behaviour that interferes with weight gain. So sometimes people will say that they can see that they're underweight, they need to gain weight, and they just can't explain why they're not gaining weight. And it's clear that they're doing things to manipulate their weight and prevent weight gain. And that's relevant for people with diabetes as well. There's also a disturbance in the way the person's body weight or shape is experienced, with undue influence of the shape and weight on their self-evaluation, their self-esteem, and how they see themselves as a person. For a diagnosis of bulimia nervosa, the self-evaluation is unduly influenced by body shape and weight, as it is in anorexia nervosa. The person will tend to try to restrict their dietary intake, but that leads to recurrent episodes of binge eating and then inappropriate compensatory behaviours such as self-induced vomiting, misuse of laxatives, diuretics or other medications, or exercise. Manipulating insulin would fall into that category as well. So, what then is the link with diabetes? Why are we talking about eating disorders and diabetes? So we know that type 1 diabetes is a risk factor for developing an eating disorder, and someone with a diagnosis of diabetes is twice as likely as their peers to develop an eating disorder. Issues and concerns about body image are endemic in society these days, particularly with the increase in social media. Everywhere you look, there are photographs of people showing off amazing bodies, restricted dietary intake. There are adverts for diets and exercise. Everywhere you look, every other week there's a new diet being advertised with the promise of amazing results to get you the body that you so desperately want. And diabetes is often diagnosed around about the same time as an increase in body image concern occurs. So in adolescence, when the person's body is changing as they're growing up. We know that 30 to 40% of people with diabetes will manipulate their insulin in order to control their weight at some point. So prior to the diagnosis of diabetes, the person may have lost weight because of the hyperglycemia and the effect of the diabetes. And often in society today, weight loss is congratulated, and that is quite is positively reinforced within society and within the family, and the person may want to continue to lose weight. After the diagnosis of diabetes, they may regain some of the weight that they had lost if their glycemic control is quite good, and they may then develop the belief that insulin makes me fat or insulin makes me gain weight. And then they might start manipulating their insulin or not taking insulin or underdosing insulin in order to become hyperglycemic, which they know will help them lose weight. So other people who develop eating disorders will need to restrict, vomit, take laxatives, or use significant exercise in order to lose weight. For people with diabetes, it can feel much easier. Just reducing or omitting their insulin can lead to pretty drastic weight loss. As you may know, anorexia nervosa has the highest mortality rate of all mental disorders. If you add in type 1 diabetes to that mix, the mortality is increased by 4 times, and that's from a combination of starvation, as you would expect in anorexia nervosa, together with the complications of diabetes and also suicide. The other issue is that as diabetic control begins to be managed, the person might experience hypoglycemia, which feels like quite uncomfortable and may lead to overeating. And if they're predisposed to an eating disorder, that might feel quite uncomfortable. So they might be desperate not to reach states where they're hypoglycemic, so run with higher sugars, and again that will result in weight loss. So what are the warning signs that families or clinics might be able to look out for? If the diabetic control appears unexpectedly poor, so from measuring blood glucose or glycosylated hemoglobin in the clinic setting, family might notice that the person is showing symptoms similar to before the diagnosis, so they might be drinking lots, going to the loo quite a lot and losing weight. They might be distressed when they're being weighed at clinics or avoid going to clinics because they don't want it to be found out that they've been manipulating their insulin or that they have concerns about shape and weight. They might be reluctant to test the BMs. They might continually ask for new meters if they have a permanent meter. They might want to inject out of sight of others, or come up with beliefs like insulin makes you fat, They may be hospitalised with diabetic ketoacidosis, have high HbA1c and present with diabetic complications earlier than you would expect. They might also be very low weight, obviously, like someone with anorexia nervosa without an eating disorder, and all the physical complications that might go along with that. I've put a link there to the DEPS-R. Now that is the Diabetes Eating Problems Survey revised, which is quite a good screening questionnaire that can be used in the diabetic clinic to help. So you can either use that as a scoring questionnaire, or it can be helpful talking through some of the questions just to see what kind of thoughts and beliefs come up from that. So just briefly, some of the risk factors for someone with a diabetes developing an eating disorder. So in the early stages, there's this need for constant glycemic control, counting carbohydrates, calculating insulin dose, portion controls, dietary restraint. All of these things can lead to the person becoming quite focused and obsessed with numbers, and we know that this is a big issue in people with eating disorders. If they are quite perfectionistic already, this might be taken to the extreme, and any dietary restraint or nutritional deprivation can lead to somebody with a predisposition to an eating disorder actually developing that eating disorder. As I mentioned earlier, it's likely that the person will regain some of the weight that they lost prior to the diagnosis, and that can be difficult for them to manage, and there might be subjective or objective binges when the person's hypoglycemic. And any pre-existing negative feelings about body shape and size are obviously relevant, as they are with anyone with an eating disorder. So early on, people will find that manipulating the insulin dose can lead to weight loss. How might they go about this, and what might we need to look out for, or how might we need to help them? So they might intermittently emit their insulin, so that can include switching off a pump if they have one, or putting water in the chamber of the pump, so the readings from the pump will say that they're getting the correct dose of insulin, but they're not actually getting insulin, they're getting water. They might underdose the insulin, so they might reduce the short or the long-acting insulin, or they could reduce the basal rate of the pump. Another thing that they can do is not to cover the amount of carbohydrate that they've had in a binge, and that will lead to significant hyperglycemia, and that's the kind of purging effect where the term diabulimia came from. It's possible also to dilute the insulin or to heat it in a microwave, which would destroy the insulin, so it looks like you're giving yourself insulin, but it's not actually active. They might delay administration or impair absorption by injecting into scar sites, or injecting too soon before the needle's actually in the subcutaneous tissue. And there may be issues with falsifying monitoring, so it can dilute blood samples before reading the BM machine, or switching off or suspending the permanent monitors from which the readings are taken at the clinic. So in terms of prevention or early intervention, we need to really balance the kind of education about the long-term effects of diabetes with the potential for increasing eating disorder risk. Obviously, it's very important for the person to understand diabetes, the carbohydrate metabolism, and to manage that safely. But we know that these kind of counting and monitoring that needs to be done can be quite risky in someone with predisposed to an eating disorder. Someone with diabetes and an eating disorder will generally know the risks, so it's not an issue of needing more education about diabetes. It's the fact that I know the risks, but the fear of gaining weight far outweighs the risks of the diabetes. So I'm I am willing to take that risk at the moment, or I feel compelled to take that risk at the moment. And the risks of diabetes are often longer term, whereas the fear of weight gain is immediate, and that is the same with other eating disorders too. Management issues might depend on the setting, so if you're in an inpatient setting, you may need to take control of the person's insulin prescribing and administration in order to ensure that they're getting the correct dose. The most important thing really is the need for good multidisciplinary work between the eating disorder or mental health teams and the diabetes teams, with clear communication about risks, roles and responsibilities. Obviously, nutritional management is essential in an eating disorder and in diabetes, but the issues might be quite different if the person has diabetes and an eating disorder. Someone with diabetes without an eating disorder would tend to take their insulin before eating, so the insulin covers the meal that's coming up. For someone with an eating disorder that may be restricting, it's important to take the insulin after, so you know exactly what the person has had and how much insulin is required. And the last point there is that it may be necessary to use the Mental Health Act in order to manage the eating disorder, which can include management of the insulin. Education for patients might be quite different for someone with diabetes compared to someone with an eating disorder. So someone with diabetes, we would want them to be reading labels, weighing food and being quite controlled about the carbohydrate they're taking in. Someone with an eating disorder, that's going to likely increase their risk and increase the amount of rules that they have around food and eating. So we'd want to, the education for someone with an eating disorder and diabetes needs to be quite carefully considered in how to balance the risks of the two coexisting disorders. So just in summary, that was a very brief run through of some of the issues. So diabetes can and does increase the risk of an eating disorder. Having an eating disorder and diabetes has significantly greater risks than having either disorder alone. We find that it can often be quite difficult to engage people in either the diabetic or eating disorder services, because as with other eating disorder behaviours, the person doesn't want you to take those away because they're there to help control the eating disorder, to control weight and to manage difficult emotions. So the thought that going to a diabetic clinic or an eating disorder clinic will mean that they have to give up these behaviours is very difficult. So it can be difficult to engage, and we need really good links between eating disorder and mental health and diabetic teams, with joint clinics proving quite effective in some areas of the country, and definitely joint training, education, and just having the links with colleagues in other services. So again, I'm happy to be contacted to discuss anything further. Thank you.